Welcome to this explainer. Let's jump right into a startling statistical paradox happening in India right now when it comes to childbirth. Over the past couple of decades, the push for institutional deliveries has been a massive public health success. It saved countless lives. But that exact success has ushered in a hidden crisis. We are seeing a rapid, dramatic rise in surgical childbirths, specifically cesarean sections. Today, we're going to unpack exactly why a procedure that should be a last resort, life-saving medical intervention is fast becoming the routine default for welcoming new life into the world.
54%. Let that sink in for a second. According to the latest National Family Health Survey, that is the staggering rate of cesarean sections happening in India's private hospitals today. That literally means more than 1 in every 2 women walking into a private clinic to deliver a baby is ending up in an operating room.
And just to put that into perspective, this reality starkly contrasts with global health standards. The World Health Organization clearly recommends a sweet spot of about 10 to 15% at a population level. That's the baseline needed to save the lives of mothers and newborns during complications. But private facilities in India? They are drastically overshooting that mark, pushing way past 50%. And studies show that once you go above that 15% threshold, we aren't actually improving survival rates, we're just increasing unnecessary surgeries.
To really wrap our heads around this, here's what we'll cover in this explainer. First, India's C-section epidemic. Second, the business of birth. Third, culture, fear, and astrology. Fourth, the hidden health costs. And finally, midwives and the way forward.
All right, let's kick things off with Section 1, India's C-section epidemic, the statistical divide.
So there is a massive, stark contrast between facilities here. Public hospitals, which handle about 3 in 5 births, are hovering near an optimal 17% mark. And that's great. It reflects an improved capacity to provide emergency care without over-medicalizing the whole process. But private hospitals have surged to that alarming 54%. When the rate in private care is literally more than triple that of public care, it proves this trend is being driven by a whole lot more than just clinical necessity. And geography plays a huge role here too. It's absolutely crucial to realize that higher surgical rates don't automatically mean safe for mothers. For instance, the state of Telangana reports a staggering 62.2% C-section rate, the highest in the country. Yet when you look at maternal mortality, Telangana sits at about 48 deaths per 100,000 live births. Meanwhile, a state like Kerala has a much lower surgical rate, around 41%, but boasts a vastly better maternal survival rate of just 24 deaths per 100,000. So for sure, more surgeries simply do not equal better outcomes. So what does this all mean? It brings us to a compelling medical mystery. If these surgeries aren't strictly required to save lives, and they aren't necessarily improving survival rates on a broader scale, what exactly is pushing so many women into the operating room? Well, let's follow the money. That brings us to Section 2, the business of birth, economic incentives.
Think about the sheer arithmetic of a hospital for a second. A normal vaginal delivery requires immense patience. It takes 6 to 12 hours, sometimes even more, of continuous monitoring. The schedule is completely unpredictable, and honestly, it brings in lower hospital revenue. On the flip side, a scheduled C-section takes under an hour. It is highly predictable, you can easily schedule it during standard working hours, and it results in a significantly higher financial payout for the facility. Basically, there's a complex web of financial incentives nudging the entire system towards surgery. Private hospitals often invest heavily in infrastructure, right? So they need high surgical volumes just to repay their loans. Then there's structural issues. Government insurance schemes like Ayushman Bharat offer fixed payouts for C-sections, around 11,500 rupees. But historically, they haven't reimbursed private facilities for normal deliveries. Plus, we're seeing the rise of defensive medicine. Obstetricians are facing massive time pressures in understaffed clinics, and they fear litigation if a long, unpredictable labor goes wrong, so they often opt for the perceived control of a surgical delivery. But it's not all on the hospitals. Let's look at Section 3, culture, fear, and astrology, the demand side. Believe it or not, many families actively request these surgeries. A really unique cultural driver in India is the desire to schedule births on astrologically auspicious dates, known as muhurat. Families will literally consult astrologers and book exact times for the baby's arrival. Then there's a growing urban mindset, often labeled too posh to push, where surgery is just viewed as a modern convenience. But perhaps most fundamentally, there's a deep-seated fear of labor pain, and this is compounded by a very real lack of dependable pain relief options, like epidurals, in many hospitals. When women aren't supported through the anxiety of labor, surgery just feels like the safer, easier escape route. Now let's talk about the real-world impact in Section 4,
the hidden health costs, toll on mothers and families.
We really need to humanize these numbers for a second. Take this quote from a community meeting in Bardpur, Rajasthan. A young mother said, "I struggled to lift water containers and care for livestock for weeks after the surgery." For rural women or anyone without extended maternity leave and domestic help, the grueling physical recovery from a C-section completely disrupts their lives and livelihoods. The operation doesn't just end when they leave the hospital. It alters their ability to survive and work for weeks or even months.
And treating this major abdominal surgery as a routine convenience, it comes with severe physical risks. We're talking higher risks of hemorrhage, infection, and complications in future pregnancies. And it affects the baby too. Neonates born via C-section face higher chances of respiratory distress, and they often miss out on early breastfeeding, which provides crucial, life-saving antibodies. And then there's the financial shock. The average private delivery costs over 39,000 rupees. That is about 17 times higher than a public hospital. This massive out-of-pocket expense forces many vulnerable families into crippling debt, where they literally have to sell assets or cut down on food and education.
So how do we fix this? Let's dive into Section 5, Midwives and the Way Forward, Tangible Solutions.
Okay, so one of the most proven, globally recognized solutions is midwife-led care. And this is a complete paradigm shift. Instead of blaring monitors, rushing doctors, and a highly medicalized environment, midwives provide constant, reassuring support. They stay present. They do less medical intervention and do a lot more to actually empower the mother. By helping women navigate natural labor progression with confidence, midwives dramatically reduce the demand for surgical interventions and pain relief. It's a real game changer.
And to put the potential impact into perspective, research based on the Lancet series on midwifery suggests that scaling midwifery across India could prevent a staggering 1.1 million unnecessary C-sections every single year. It could also save hundreds of thousands of maternal and neonatal lives. Actually, states like Telangana, specifically at centers like Fernandez Hospital, are already pioneering this. They are proving that continuous midwifery support safely and effectively lowers C-section rates.
So how do we get there? We have a clear, multi-step roadmap. Step 1 is data transparency. Hospitals absolutely must undergo mandatory clinical audits using the WHO's Robson classification to spot patterns of overuse. Step 2 is reforming the money. Insurance needs to pay the exact same rate for normal and surgical births to remove that profit motive. Step 3 is heavy investment in training and scaling midwife-led care units. And Step 4 involves adopting independent second opinion protocols before a doctor can greenlight a non-emergency surgery.
Now, the absolute biggest takeaway from this explainer isn't about restricting anyone's choice. Obviously, C-sections will always be a critical, life-saving necessity for some. The real goal here is removing the systemic coercion, the profit motives, and the institutional fears. It's about ensuring that when a mother goes into labor, she's supported, respected, and totally able to make genuinely informed decisions about her own body, rather than being rushed into what feels like a commercial transaction.
I'm going to leave you with this thought to ponder as we wrap up. As a society, will we choose to reshape our healthcare incentives to actually support natural, empowered births? Or will we just stand by and allow profit margins and systemic fear to permanently over-medicalize the very first moments of human life? Thank you so much for exploring this vital topic with me today.